I'm Christine Cannellin for iTube TV. There are many new technologies in development aimed at improving the way that glaucoma is managed or simply eliminating the challenges of patient compliance. One challenge may be getting physicians to utilize these interventions over standard therapies used today. I'm curious to hear what the experts have to say. I have Dr. Carlos Buznego and Dr. Randy Craven joining me here today. Thank you, guys.
Thank you.
So let's talk a little bit about the field of glaucoma. What are the most significant changes that you expect to see in this field maybe over the next few years?
Well, there's so many things going on right now, Christine, but I think that our biggest area we're going to see changes in is going to be in surgical improvements that we've been waiting for a long time. We're going to finally see some devices that will help us get the pressure down more safely for the patients, hopefully without problems that can occur from our glaucoma surgery, such as blebs. And the patients should end up feeling better about their eyes, better pressure control, done easier by the surgeon. So I think we're really heading towards a much better situation than we've had in the past.
Mm-hmm. And Carlos?
I think it's been a really exciting time. Really, most glaucoma surgery that we're doing now is surgery that's really been around for a long time. There's been modifications with anti-metabolites, but really it's surgery that's been around for decades. And we have some new technologies that are exciting. They're kind of around the corner. A couple of them have been out for a short time and really giving patients an option. Mm-hmm. And I think that's really an important thing to think about. The traditional patient was very comfortable being treated for medical therapy, doc, whatever you say. And really the new patient, the savvy patients and the patients who are always hungry for information, oftentimes aren't satisfied with the traditional therapy of use this drop every day for the rest of your life. They really want to try to fix their problem, whether we see that with LASIK surgery, with plastic surgery. And I think we're going to see a little bit of a wave of that in glaucoma surgery, patients wanting to try to, quote-unquote, fix their problem, mm-hmm. and a surgical procedure may help us do that.
Mm-hmm.
You know, Carlo, that's a really good point, because I think that our evolution from patients' expectations, it's been enhanced by things such as LASIK. It's left them with the idea that, you know, this should be an easier thing to get where I want to be. And now our technology is finally catching up with that. So we're going to be able to see our patients happier, I think.
Mm-hmm. Now, what kind of new products and new technologies are you most excited about and seeing as providing the most value for glaucoma specialists?
Well, personally, one of the things I'm the most excited about is the new Glaucos eye stent. That's a very small device. It was developed by Dr. Rick Hill a number of years ago. I've known Rick for a long time, since he was actually a medical student. So I've watched the whole evolution of this technology, and it's become a device that I think, once it's approved by the FDA, which is almost imminent at this point, mm-hmm. We're going to see this device gaining enthusiasm by both glaucoma specialists and, I think, cataract surgeons and the general ophthalmologists. It's a smaller device that goes in with almost like a needle across the anterior chamber to allow you to implant it into the trabecular meshwork, so it creates a trabecular bypass. And by doing that, you're allowing the aqueous to get into the Schlemm's canal in a physiologic manner, so you enhance the natural mechanism to help the pressure come down. And to me, that's really what it's about, trying to maintain physiology but enhancing pressure control. And we have that now right on the forefront with the Glaucos eye stent.
That's great.
I think, I agree. I think the Glaucos eye stent is a really exciting technology. Traditionally, a lot of our surgical techniques have involved bypassing aqueous away from its physiological drainage, and this basically is a stent that's allowing it to go through its traditional or its normal drainage, the Schlemm's canal, and it's exciting technology. At the American Academy of Ophthalmology meeting in San Francisco in 2009, Tom Samuelson presented a paper and that showed really pretty dramatic results. And in the study, there was two groups. There was a control group, which just had cataract surgery alone, versus a group that had cataract surgery and the Glaucos eye stent. And that study showed that 73% of patients who received the eye stent had pressures less than or equal to 21, which was the target in the FDA study, versus 50% of patients who had cataract surgery alone. So we should all acknowledge that cataract surgery alone does reduce intraocular pressure, but there was a statistically significant improvement. A secondary endpoint in that study was similar, 67% versus 47% of patients had a 20% or greater percent drop in intraocular pressure. So it looks like it's exciting technology, and again, it's
pretty dramatic outcomes.
Dramatic outcomes.
In addition to that, it was done very safely. You know, there were really, if you look at the problems that were associated with the implantation of the device, it was very low if almost any to speak of. It was an excellent result.
Great, and safety too. So
Yes.
great for the patients. What would you say is more important, IOP reduction or sustaining IOP control, even if the target pressures are slightly higher?
That's an excellent question, and we're actively searching for that answer right now. I think if you look at the data from the Advanced Glaucoma Intervention Study, we went back through the data on that. We did find that the absolute pressure reduction was very important. If you look, you could get the pressure down to about 12.3 millimeters on the average, and most of the pressures were under 18 on all the visits. Then you saw that those people had the lowest likelihood of having visual field progression. That was then sub-analyzed by Dr. Caprioli and Coleman as they went back through and looked at that, and what they found is that there's pressure variation more than 3 millimeters of mercury. They were finding that there was a concern that perhaps people with intermittent pressure spikes were progressing. So then they reanalyzed that again and broke it down into groups of pressures, and what they found is if you had a pressure on the average of around between 10 and 11, and your pressure variation was in the lowest tercile, that you had a high likelihood of keeping your glaucoma stable. It was about 90% likelihood if you were in that group that was at risk for progressing. And if you had either a low pressure on the average but great variation, or just high pressures with or without variation, then you were at a much higher group, up to close to about 30%. So there's a 20% difference and much more impact of that to the patient. But if you can keep those pressures down with low variation, we know that that's the best thing. And one of the things we feel might help that is surgical interventions. And that's really what is so exciting about some of the newer technologies, that we're going to be able to look at that as an option to try to give the patients the best option for pressure control, don't have to worry about things such as compliance or adherence, whatever term you want to use.
It's interesting. In the United States, medical therapy is traditionally the first step. And the problem we have with medical therapy is the cost to the patients and patient compliance.
Right.
So the pressures we see in the office oftentimes aren't the real pressures. Patients floss their teeth for the day and a half before they go to the dentist's office. Glaucoma patients use their drops the day or two before they come to see us, and we may see some good pressures that we feel comfortable with. And I think that's going to be the exciting part about having a surgery or a laser procedure that works 24/7. And I think patients kind of get that when I talk to patients about the alternatives and laser therapy, for example, letting them know that this works every day, even whereas drops obviously, and even the best patient with the best intentions misses drops, and oftentimes really doesn't tell us about it because they kind of feel they're letting us down.
And then they don't get the efficacy that they really need. So the surgical interventions really sound like that's the direction that you want to be heading in. So
yeah, but haven't been around long enough. Even when you do surgery, sometimes you need medicines to supplement it. So, and fortunately, we've had some good improvements in that area too, where the medicines work better, longer efficacy, and that keeps getting better too. So we're fortunate for that.